Welcome, everyone. We're going to get started here. Welcome to today's National Online Fellow Lecture Series. The topic today that we will be discussing is going to be ankle sprains, an update on diagnosis and treatment. My name is Eliot Hu. I'm currently one of the sports medicine faculty at Naval Hospital Camp Pendleton. But first, let's establish some ground rules here. This lecture series is sponsored by the AMSSM Online Fellows Education Subcommittee within co-sponsorships by the Education Committee and the Fellowship Committee. This is meant to serve as an adjunct to your individual program's educational programming. It's meant to provide sports medicine fellows with direct access to educational experiences with experienced AMSSM and other allied members, and at times invited guest experts in a variety of formats. This is also meant to assist in CAQ exam preparation. Please mute your device's microphone and turn off your video. We will submit questions through the chat function, which include, and please include your name and program if you wish. And I, as the moderator, will ask the questions during the Q&A session at the very end of this talk. And it'll be based on the questions that you submit, time permitting. After the program, please complete the evaluation, which will be sent at the end of the lecture. Now, without further ado, I'd like to introduce our two expert speakers today. First off, we have Dr. Michelle Henne. She is a native Floridian and a sports medicine physician at Releve Sports Medicine in Winter Haven, Florida. Releve Sports Medicine has been a BOC approved provider for continuing education for athletic trainers since 2018, and their team transitioned the free CEUs to an online webinar platform due to the COVID-19 pandemic, which has allowed them to have national and international experts present. Dr. Henne did her undergraduate program and medical school training through an accelerated 7-year medical program at the University of South Florida, where she was inducted into the Gold Humanism Honor Society. She did her residency training at Bayfront Health in St. Petersburg, Florida, where she was one of the 12 national recipients of the AAFP Award for Excellence in Graduate Medical Education. She completed her sports medicine fellowship at Orlando Health. She is the first affiliated faculty member of Florida Southern College Doctor of Physical Therapy program and the first affiliated faculty member of Florida Southern College. She is currently the head team physician for All Saints Academy and Polk State College. She has authored multiple manuscripts and book chapters on sports medicine topics. In her free time, she enjoys volunteering with the Junior League, competitive water skiing with the Cypress Garden water ski team, fishing with her husband, and playing with her 2 dogs. Next, we have Dr. John J Frazier. He is a board-certified orthopedic physical therapist, scientist, and leader in the United States Navy, currently serving as the Deputy Director for Operational Readiness and Health at the Naval Health Research Center in San Diego, California. He is also part of the teaching faculty at the Primary Care Sports Medicine Fellowship at Naval Hospital Camp Pendleton. Dr. Frazier is a graduate of the Physical Therapy program at the College of Staten Island, City University of New York in 2002, and the post-professional DPT program at the University of St. Augustine for Health Sciences in 2018. He was conferred the PhD in Education, Kinesiology, Sports Medicine from the University of Virginia in 2017, where he studied the role of the foot in lateral ankle sprains and chronic ankle instability. Dr. Frazier's specialized clinical experience includes the prevention, primary care, and rehabilitation of tactical, collegiate, and recreational athletes with neuromusculoskeletal injuries in traditional clinical settings and austere expeditionary environments. His research interests and scholarship are concentrated on ankle-foot neuromuscular function, rehabilitation, and public health of military tactical athletes. Without further ado, I'd like to introduce our speakers, and we will get started with Dr. Henne's talk.
All right, very good. So you guys should have that getting pulled up here now. All right, so thank you very much for that great introduction. And today, Dr. Fraser and I are going to be talking about the diagnosis and management of lateral ankle sprain and chronic ankle instability. And so I don't have any conflicts of interest, and Dr. Fraser will go through. He's a military service member. In terms of our objectives for today, so we are going to be talking about accurately evaluating and diagnosing ankle sprains, understanding the differential diagnosis, being able to apply an evidence-based targeted ankle management and rehabilitation protocol, mitigating the known consequences and the potentially limit those long-term ramifications. Also looking for risk factors in development of chronic ankle instability. And then Dr. Fraser will walk into being able to apply primary, secondary, and tertiary prevention for lateral ankle sprain and chronic ankle instability using evidence-based techniques. And we'll both be talking about return to work and activity program. So that's our objectives. Let's go through our outline then. So I'm going to start with anatomy, go through epidemiology, then we're going to talk through the risk factors that we can look for, talking through then the diagnosis, looking at grading of the diagnosis, physical exam techniques to help us to determine the diagnosis, utilizing the Ottawa ankle rules as part of that diagnostic strategy. Following that with imaging, walking through X-ray, ultrasound, MRI, and then getting into management, utilizing prescription medications, immobilization, functional support, surgery. And at that point, we're going to be transitioning to Dr. Fraser, who's going to talk about the primary, secondary, and tertiary prevention. From there, he's going to go into prognosis, including chronic ankle instability and its impact on gait, nerve-related sequelae after an ankle sprain, the impacts of an ankle sprain and chronic instability on the foot posture index, return to work and sport programming, chronic ankle instability interventions, and then finally looking at some of the future directions on the physical therapy front. So anatomy-wise, when we are talking about the ankle joint, the primary ankle ligament that we're referring to for lateral ankle sprains is going to be that anterior talofibular ligament, or the ATFL. There are several other ligaments of the ankle that can be injured when the ATFL is injured, namely some of the ones that you may hear about and want to become familiar with are going to be the anterior interosseous tibiofibular ligament, which is this one here, and the posterior interosseous tibiofibular ligament along the posterior aspects, as well as the interosseous ligament that become involved when we have high ankle sprains, as to name a few. Epidemiology-wise, how frequent is this? Is this something common? Most definitely. The most common lower limb musculoskeletal injury incurred by those who participate in physical activities. More than 2 million people sustain a lateral ankle sprain annually. And up to 50% of those don't seek formal healthcare management. And that includes our athletes as well. We think that our athletes they have more access to healthcare providers, and they're falling into the same boat. More than half of them aren't seeking professional treatment after an ankle injury, don't undergo proper rehabilitation. And what's the concern? The big concern here is how does that not only impact them individually, but also how does that impact us in a more systemic fashion? It provides significant healthcare burden, which is exacerbated by the decreased physical activity, the early onset ankle arthritis, and those sequelae that could be avoided. And it's very expensive. So what are the predisposing factors? And we're going to start with the intrinsic factors, meaning what about these athletes puts them at risk for having ankle sprains? The limitations in their dorsiflexion range of motion has been an associated risk factor. Reduced proprioception, deficiencies in postural control and balance, particularly a single leg balance test being positive, a lower BMI if they're female. So there's a gender association. However, in competition, the risk is actually higher in boys as compared with girls. That history of ankle sprain has been described previously. We often talk about, oh, if they have a history of it, they're more at risk. Interestingly enough, more recent research utilizing pooled results led to a non-significant risk ratio. So starting to at least question if a history of it increases the risk. greater height and foot posture index, as well as anatomical abnormalities in the ankle and the knee alignment. And anytime we talk about risk factors, this is such a critical time for that, because everybody across the country, we're all doing lots and lots of sports physicals, right? We have all the kids going back to school. And if this is something where, if we can pick up on these risk factors that these student athletes may have, we can anticipate them, impose or provide them with a home exercise program to limit their injury in the future. The same thing's true then in the extrinsic perspective. Now that has to do with what's going on in their environment. In particular, namely, what are the sports that have the highest risk? Certainly basketball is on there. Indoor volleyball, we're getting ready to start indoor volleyball season here. The landing after a jump in volleyball is one of the highest risk factors. There's also, from the perspective of soccer, if we're talking about natural grass actually is higher risk than artificial turf. And the position, being a defender, potentially you're someone who has had an ankle sprain in the past, maybe considering changing that position. High heels increase the risk as well. So what are the things for you as the sports medicine physicians that are in fellowship now? What are the things that you need to be asking your patients as they're coming into your office to seek your care? Well, timing, certainly. Is this something that was in the last couple of days, or was this several weeks, months, years ago? What was the trauma? What was the mechanism? I always harp on the folks that I work with. What was the mechanism of their injury? Why are they here? Was this chronic? Was this acute? And in this perspective, was it an ankle inversion, or was it something more atypical, an eversion, a plantar flexion, dorsiflexion? So what was that mechanism? Tell me more about the person. How old are they? How much do they weigh? What's their profession? Are they a professional athlete who needs to get back as soon as possible? Or are they maybe an adolescent? And is this a hobby? What are their hobbies? What are the things that they're trying to get back to? Maybe it's something totally unrelated. Maybe they are a laborer who their intention is just to get back onto the job, get back working. Male or female, ability to walk after trauma. We're going to talk about that some more in regards to the Ottawa ankle rules. And then therapy. Have they had any therapy between the time of the injury and now? Do they have an athletic trainer that they work with? Do they work in a place with access to physical therapy? And then do they have any other, aside from that lateral ankle sprain, looking at the ligament there, are there any other symptoms or any other concern for other damage that occurred during the injury? So differential diagnosis, we're going to talk about Ottawa ankle rules, and certainly one of the first things you want to do is rule out a fracture. Why? Because you want to start managing that as soon as you're able to identify it, and you want to manage it appropriately. What else? Well, certainly you can also have not just the ATFL sprain, you can have other ligament or capsular sprains, and up to 41% of ankle sprains do have other ligaments or capsule has been injured. What else? Well, certainly the osteochondral lesions. Those are things they can sometimes mimic, or they can occur concomitantly with an ankle sprain. And then syndesmotic injury. That's going to give you an idea of, okay, this may take a little bit longer. Let's start talking with the coaching staff. Let's start talking with the physical therapists, athletic trainers. We've got a syndesmotic injury, not just a lateral ankle sprain, so we can appropriately set expectations on returning to activity. So with the first instance is going to be to rule out a fracture and wanting to use the Ottawa ankle rules to do that. Ideally, we want to do that within a week. Why? Well, because we already start to have bony remodeling and we want to get appropriate treatment underway. So let's talk about those Ottawa ankle rules then. The best place to start is going to be looking at the posterior edge or tips of the lateral malleolus. That's on the dorsal aspect of either medial or lateral malleoli. Another place that if they're having pain is at the base of the fifth metatarsal, and then finally pain on palpation of the navicular. So if one of these areas do have pain associated with it, that is considered a positive Ottawa ankle test. Also, the inability to bear weight, and how do they define that? That's in regards to being unable to walk at least 4 steps. From a sensitivity perspective, if they don't have any of these things, you can feel very confident that it's very unlikely that they have a fracture. The sensitivity is very high. The specificity, the ability to rule it in, it's low. The positive predictive value, it's very low. So just because they have those pains, certainly that's the reason why sometimes physical therapists and athletic trainers will send folks in. They want to get the ankle, x-rays, and they certainly want to rule this out if it is positive, but it doesn't always associate necessarily with fractures. But the negative predictive value, so if you don't have any of these things, is very confident. You can feel very confident that this person is very unlikely to have an ankle fracture. Now, only 15% of people who have a lateral ankle sprain are diagnosed with fracture. So it's not that common, but you certainly want to be mindful of it. So let's say now we know, okay, they've got an ankle sprain. Well, how bad is it, right? That's often what the athlete or the parent is asking you. Well, similar to if we were talking about the MCL, the medial collateral ligament of the knee, they grade the ankle sprains 1, 2, and 3, 1 being mild. If you were to get the MRI in a grade 1 injury, you're going to see some fluid around the ligament, but you don't have the microligament lesions that you would see with grade 2. You don't have that additional stretching injury that has gone on with the grade 2. In the grade 2, you'll also see on that MRI some fluid within the ligament there. And then grade 3, now you're talking about a full thickness, full ligament lesion, certainly severe. Sometimes they have associated hematomas. And at this point, you're starting to look for, do they have a positive anterior drawer test? And you're starting to suspect that they did have rupture of those lateral ankle ligaments. So physical exam wise, when we talk about the anterior drawer test, I have a picture of that in the bottom right hand corner here. And I'll tell you, this is a good depiction of it. My personal preference is I tend to actually hold around the calf from encircling the calf with my thumb up front and then my fingers behind. And then in terms of my bottom hand around the heel, I bring my 4 fingers around the heel and I bring my thumb up top. Why is that? Well, because my concern is that if you don't have the right angle or the trajectory, you may put yourself at risk of having a negative test, a false negative. And so by doing that, I'm able to somewhat change the position depending upon how their ankle allows for more mobility to be able to really get a good assessment here. So we utilize this to look for joint laxity. And what are we looking for? Well, when they had evaluated this versus controls, they have seen that around 3 millimeters of anterior translation is what you're going to be looking for a positive anterior drawer test. Again, the specificity, being able to rule it in, very high. Sensitivity, a little bit lacking. So now that sometimes comes in because of guarding. Maybe that comes in because you don't have quite the right angle. But those are things to be considering. If someone has a significant amount of joint laxity, it may be difficult to discern utilization of the anterior drawer test. It is ideal if you do it around 4 to 5 days post-injury. Why? If they had a significant hematoma, that might be blocking space, and so they may not have that really good anterior drawer test you'd be hoping to find, whereas once it starts to have some soft tissue reabsorption going on, you may be able to get a better exam. And then also, it's always helpful, really for any joint, to do those side-to-side comparisons. What is this person's normal? Especially if they've got a good side, let's compare the two and see how these correlate. And then in the top right picture, that was looking at the ultrasound measurements of the ATFL, and that's how they had discerned those mean measurements for an abnormal versus a normal ATFL. And looking at it under, and that's the beauty of ultrasound, is being able to look at the ligaments and musculoskeletal structures in a dynamic way. And so they were doing it under stress there. So American College of Radiology's appropriateness criteria. So we're going to walk through a few different scenarios. In this one, we've got, they're all going to be an adult or child 5 years of age or older with acute trauma to the ankle. Okay, in this situation, we have no exclusionary criteria present, aka no signs of peripheral neuropathy or other neuropathic symptoms. Negative Ottawa ankle rules. Initial imaging? Nothing. Right? No, nothing at this point is necessitating the need for imaging. So let's look now. All right, in this circumstance now, they've had pain for more than a week. It hasn't quite been 3 weeks yet. Again, no neuropathic symptoms, but positive Ottawa ankle rules. What are we going to do? Well, let's get x-rays. All right, so in this situation, now we have neuropathic symptoms. Negative Ottawa ankle rules. Where should we start? Still want to start with x-rays now. We may consider getting a CT. How about going back to the situation before, the pain for more than 1 week, less than 3, no exclusionary criteria were present, so no neuropathic symptoms, and the initial x-rays were negative, but they're still having symptoms. And you're like, oh, man, I'm not finding it. It wasn't a fracture. What could be your next step? Well, let's get some additional imaging here. So you're looking at potentially MRI, CT, and basing that off of your physical exam and what your suspected diagnosis is. Now, in this situation, we've got no neuropathic symptoms. X-rays demonstrate a fracture or a potential osteochondral injury. So what might we need now? Some additional imaging may be indicated, MRI, particularly to look at the osteochondral lesion, and CT if there's some concern regarding the fracture and displacement. Now, how about x-rays are negative for bony injury? Physical exams, radiographs, they demonstrate an alignment abnormality. So we're going to look at those in a moment. And we're starting to suspect there might be a syndesmotic or a ligamentous injury or even a dislocation. What are we going to do next? At this point, we have a fair amount of options. Certainly, if we're thinking about getting an MRI or a CT, most of the time, insurance is going to mandate, in at least the non-military setting, that we get x-rays first. And then the other thing to consider is that if someone does have what you're suspecting to be a syndesmotic injury or dislocation event, you do want to consider x-rays of the leg. And why is that? It's actually because there is a mechanism that can cause this type of injury that also causes a spiral torque to the proximal fibula. And so you want to look to see, is there a fracture there at that proximal fibula? I actually had a guy with dementia who that had occurred, and you know, I had palpated the proximal fibula, and he didn't have necessarily pain, and he was trying to walk around on this very significant ankle fracture. And so I said, no, let's just go ahead and get x-rays, and there was had a fracture there at the proximal fibula. So when we get x-rays, what type of x-rays do we want to get? We want a 3-view, and we want that to be an AP, meaning a picture from the front. So they're going to have their foot facing right at you, right at the x-ray tube. And that's going to be your AP view. Now the Mortise view, they're going to ever so slightly translate their foot towards in a medial rotation, and you're going to then get that Mortise view. The beautiful thing about the Mortise is that you're able to look to see what is the amount of clear space. It really should be a symmetric amount of clear space between the talus and the medial and lateral malleolus. So you're looking for symmetry there in that spacing. The lateral view can really be helpful if you start to think, maybe I'm seeing an osteochondral lesion, or maybe there's a fracture here, and you're looking to corroborate that with the lateral. Maybe you see that lucency again in the talus, and you're like, man, this looks like an osteochondral lesion, let's get the MRI. Or maybe it's a fracture of the lateral malleolus, and you get on the lateral, and now you're assessing what type of displacement they have. With ultrasound certainly is very sensitive. At this point in time, the most recent literature is demonstrating a lack of the specificity But what are we looking at? It's a great imaging option to be able to get a dynamic assessment. It's a great imaging option if you have, let's say you have an opacification that you're seeing and you want to assess, is this a loose body? Is this something that's in the joint versus extra-articular? Ultrasound can really help you to delineate that. You get that dynamic exam, but it is operator dependent, right? It depends on what quality ultrasound you're using and how efficient or effective, how experienced are you as the technician. Certainly right now, you guys are just starting your fellowship. So, the expectation here is that by the end of your fellowship, you're certainly more proficient than you are at the moment. Now, from an MRI perspective, when do we consider the MRIs? High-grade ligament injuries, especially if we're starting to suspect that they have an associated injury with that, osteochondral defects, syndesmotic injuries, occult fractures, and MRI is a very good option. You can see here being an osteochondral lesion, MRIs really just light up, and they'll show you that. Treatment-wise, so this is an older study but it reflects what continues to be the case, right? If you don't address in the room, what can people expect, right? They're coming to you as a sports medicine physician. What can they expect? When can they get back on the field? They have had this significant injury. When can they get back on the field? When can they get back to walking? When can they get back to their activities? And so at the initial office visit, one of the biggest things you're looking to determine is what is their diagnosis? And if you don't have it yet, you've at least started the process to discern what the diagnosis is. You want to be able to talk with them about what to expect for the duration of rest. Is this something they can return to activities as tolerated right away, or they need to spend a certain period of time resting? And things like fractures are going to help to delineate that. When should they follow back up with you? Is that something, do they need to see you in 2 weeks, in 6 weeks? What should be the time frame here? When can they return to normal weight bearing? And that's going to be dependent again on what particular injury it is. What should they expect regarding the results of their treatment? When and again, that comes down to that. When are they going to be back on the field? When are they going to be doing single leg activities? When are they going to be weight bearing? The medication, that's a really great time to talk about what the medication options and strategies are, and then recommendations to prevent recurrence. And then finally, something that we've been talking a lot more about recently is addressing their mental state. This is their identity. They identify with being able to participate in their sport. And at this point in time, they feel as though they've lost their identity. So starting that conversation so they feel that you're an ally. Anticipatory guidance. So we know that pain does typically decrease very rapidly within the first 2 weeks. However, at 1 to 4 years, many of these athletes will still be experiencing pain. Many of them are going to have recurrent sprains, and many of them are going to report instability. And many of them are going to have anterior impingement. So we want to give them that anticipatory guidance, but we also want to be mindful that not everybody gets better with the typical management strategies. Medication-wise, so there's oral and topical anti-inflammatories. These help to result in less pain in the short term without significantly increasing the risk of adverse events. That's in contrary to opioids. Again, effective for pain relief, but adverse effects are certainly there. So we want to be much more hesitant about those. Anti-inflammatories, getting back to those, there's been this ongoing conversation of how much is that going to impact the natural healing response. We talk about it a lot with platelets and PRP because it inhibits the platelet functioning. And so again, in this circumstance, trying to discern when would be the ideal time and in what form or formulation should we be utilizing them. Tylenol is equally effective as anti-inflammatories for the pain, swelling, and the range of motion. So maybe we consider the Tylenol or a topical anti-inflammatory first, potentially progress from there if they're still having breakthrough pain to oral anti-inflammatories, and then going from there to opioids, but certainly as a last resort. Immobilization. What we know is that if we immobilize ankle sprains for a long duration of time, these people do worse. So we want to be very cautious, very hesitant with how long we're going to immobilize somebody. A short period of time, less than 10 days, is going to, and then transitioning them from immobilization to something a little bit more functional is going to get them those benefits for decreasing pain and swelling while improving their overall functional outcome. We know that if we leave someone in an ankle boot for 6 weeks, when you see them back in 6 weeks, they're going to be atrophied, they're going to be stiff, their proprioception and neuromuscular control is going to be terrible, and it's really going to take them a significant amount of time. So we want to be cautious with the duration time for mobilization. Functional supports, as soon as we're able to, we really want to start transitioning people to the functional supports for lateral ankle sprains. What we know is that the lace-up ankle brace and the semi-rigid brace should be preferred on the functional support side. Kinesio tape, unlikely to provide that mechanical support to unstable ankles. So maybe staying away from the KT tape, but looking at that lace-up brace or semi-rigid brace. And what should we expect? So if we have a grade 1 injury, we should be expecting that for the first 2 weeks, if they're working, they're going to be mostly sitting and working, not exceeding 10 kilos of lifting, and limiting the amount of standing and walking, particularly on uneven surfaces. By the end of 4 weeks, we're expecting that they're going to be returning to full work activities. Now that's in contrary to the partial or total rupture of ligaments here, where the first 3 to 6 weeks even we're mostly sitting work, we're having more of that sedentary situation. And then at 8 weeks, returning to activity. And then in the case of surgery, going through the postoperative rehab protocol as delineated by your foot and ankle surgeon. And what are the things, again, that we want to be mindful of here is working with a therapist, someone like Dr. Fraser, on this, addressing those emotional impacts, progressively moving people back to their sport or their work-based activities so that you can help to harden and promote the healing of that ligament so that they can return to their functional capacity. Prevention, bracing and taping does reduce the risk of recurrence. KT tape may have a preventative effect in the risk of recurrence due to the effects on the postural control. And then coordination and balance training from a neuromuscular perspective help to prevent recurrent ankle sprains. So those are some things that you can start to talk about, and you can also be talking about that during their pre-participation physicals. Surgical intervention, if someone requires a quick recovery, that is the duration of time, particularly those professional athletes, that you are going to want to have those conversations with your respective surgeons to discern, is this going to be a good candidate to consider surgical intervention early, or should we try to rehab this person first and then see how they do? The caveat would be certainly if someone has developed, especially chronic ankle instability, or maybe I had someone recently who had an osteochondral defect, and we found that it was secondary to the chronic ankle instability and a history of a grade 3 ankle sprain, and they were one where not only did the surgeon address the osteochondral defect, but also reconstructed their ligament so that they had that they no longer had that instability and had protected the talar dome. Knowing that and balancing this with the fact that 60 to 70% of individuals do respond to a non-surgical treatment protocol. And then my last slide here before you transition over to Dr. Fraser, I'm talking about chronic ankle instability, and he's going to talk about this as well. 40% of those with lateral ankle sprains do go on and develop chronic ankle instability, particularly if, and these are some of the things that it's so helpful to have a physical therapist as part of your team so that they can be checking in and making sure that your athletes are meeting these benchmarks. So if they're not able to jump and land within 2 weeks after that first lateral ankle sprain, if they're having deficiencies in dynamic and postural control, altered hip and hip joint kinematics, and having persistent mechanical instability or ligament laxity at 8 weeks after. So when we get into the chronic ankle instability diagnosis, CAI, we're talking about complaints of pain, swelling, or instability symptoms in combination with recurrent sprains for at least 12 months. The concern here is that long-term association with joint degeneration, as well as the osteochondral lesions, as well as the fact that we know if one of our athletes goes on and develops CAI, they're going to have decreased physical activity, decreased quality of life, and increased fear of re-injury. So we'll go through questions at the end. And so I'll transition at this point. And if you know any athletic trainers looking for a job, have them reach out to me.
Thank you, Dr. Henne.
Great. Thank you so much. That was a great presentation, Dr. Henne. Let me pull up my slides real quick. I was going to say, shoot me a message. I could reach out to my athletic training counterparts. All right. So let me put it in presentation mode. Can you guys see the slides? All right, great. So at this part of the talk, I'm going to talk about that it's not just an ankle sprain, right? And I think Dr. Henne did a great job setting this up to say, you know, and you hear this all the time, not only by lay people, but also by clinicians saying, oh, it's an ankle sprain, it'll self-resolve. I hope at the end of this talk that, both from Dr. Henne's talk as well as mine, that you'll have a different perception of ankle sprains. So just disclosures, I am an active duty service member. I'm a commander in the United States Navy. And so this is my views, and not necessarily reflective of the government and or AMSSM, ACSM, or any other entity that I represent. So once again, we know that ankle sprains are ubiquitous, and they involve extremes of motion at high velocities. Okay, when we're talking about, and I want you guys to think about, especially when we're talking about evaluation and treatment, you're going to hear some recurrent themes that I talk about. Number one, you got to take care of the individual patient, because these conditions where there's a common characteristics, but there's a wide degree of heterogeneity in the blast pattern of from a pathoanatomic, from an impairment perspective. So typically they involve inversion, but the second leading cause is actually external rotation on the fixed foot, or respective internal rotation of the foot that stress those ligaments, the ATFL and the calcaneofibular ligaments. Now, some of the point of flexion, you may or may not have a point of flexion component as part of the injurious mechanism. As a result of the inversion or adduction, and I started thinking about at some point, where think about all the forces, all the moments that have to cross the foot in order to reach the ankle. And I started looking specifically, and that's what kind of sparked my interest about looking at the foot. And any astute clinician should be looking above and below the joint, right? And the I'm not going to belabor the Ottawa rules, but examining, and it doesn't take long to do, so it's just something to consider. In the talocrural joint, the traditional aspect of when we're talking about ankle sprain, you have lateral distractive forces. You have compressive forces on the medial side, as well as that internal rotation and adduction moment, but as well as in the lateral midfoot. And we know that lateral midfoot injury is also ubiquitous in lateral ankle sprains because of the same forces. Now, once again, the anterior talofibular ligament is the most commonly sprained ligament, but you also have that end is stretched up to 20% of its resting length. But in the midfoot, we see about 1/3 of individuals with lateral ankle sprain will have midfoot, specifically talonavicular, bifurcate ligament, which calcaneocuboid ligament injury. And there was a study that was done by the Sondergaard, that was conducted in the emergency room. And essentially what they did is they looked at these individuals and followed them through the injury course, and actually found that number one, midfoot injury due to inversion, it was misdiagnosed as a lateral ankle sprain and isolated midfoot injuries. And the other interesting part of that is that functional pain and functional instability occurred at the same rates as individuals with isolated lateral ankle sprains. So that's why I think it's important to examine the midfoot. Now, Dr. Henne explained that 40% of individuals have gone to develop chronic ankle instability, and this has been operationally defined as individuals that had a substantial ankle sprain that had greater than 1 year chronicity. They have episodic or perceived giving way of the ankle that limits function. And because of that, you have this wide heterogeneous condition that has both mechanical, sensory perceptual, as well as motor and behavioral impairments. And those are mediated both personal intrinsic factors as well as environmental factors. And there's a sliding scale, pertaining to how severe is the function, the activity limitation, or the limitation of function. We know that individuals with chronic ankle instability walk differently. They walk slower, wider-based support, no different than you see in some other neurological conditions. They have increased shank external rotation, which we explained before as part of the mechanism, as well during the injury, as well as increased ankle foot plantarflexion, supination, and internal rotation. So there's also decreased stride-to-stride variability, which indicates a neurophysiologic constrained system, as well as increased plantar pressure variability, which in that particular case indicates a highly variable or lack of neurophysiologic constraint. We know that individuals that, with chronic ankle instability have a more lateral center of pressure progression through the foot as they walk, with decreased pressure in the heel and increased pressure in the midfoot. They also spend increased time in the rear foot and midfoot during stance. And there may be plausible reasons why that is, especially as it pertains to diminished plantar sensation, as well as increased plantar pressure in the outside of the foot for longer periods of time. We also know that nerve injury is also common. If you're looking at grade 1 sprains, it's only about 10 to 17%. When you start going up to grade 3 sprains, now, mind you, these are fleeting results, and they've the studies that have looked at nerve conduction in this population, that they actually resolve to a certain extent. But that's pretty ubiquitous, where you see about 85% of your individuals that have both tibial and fibular nerve impairment. Now, in the individuals with chronic ankle instability, they also have been found to have increased latency and delay in the fibular nerve. But as you start going a little bit more central, these individuals with chronic ankle instability have diminished spinal and corticomotor excitability. So there's inhibition that occurring, as well as changes in the primary motor cortex, as it pertains to the fibularis longus. So this is a long way of saying, hey, these conditions may just be beyond the ankle, and there's other facets to this. So as I mentioned earlier, that we also know this population has decreased plantar cutaneous sensation, and that may contribute to the diminished balance observed in this population. Now, cutaneous neurocoding, which is the culmination of all the afferent information that feeds the brain and gives our brain, that proprioceptive, that which is both, joint position sense as well as kinesthesia, is then could potentially have impairment due to these neural injuries. Now, interestingly, it's been shown that some of the slow adapting cutaneous afferents, we also oftentimes think about, it's a ligament injury, decrease of somatic sensation because of that ligamentous injury, but it's actually more so because of perhaps some of the muscular and the cutaneous afferents that are injured. So, in summary of this piece, I think the big clinical takeaway is that between decreased tactile, ligamentous, capsular, and muscle afferents, that somatization, in conjunction with some of those central motor inhibition and sensory perceptual issues, is probably leading to that alteration of biomechanics that I just talked about. So a few years ago, and it's getting up there in years as well, five years now, we wrote a clinical commentary describing how the midfoot, and in addition to the rear foot, could contribute to the impairment that we see in both lateral ankle sprain and chronic ankle instability. So it's plausible that midfoot ligamentous instability, is plausible contributory, right? So with about a third of those individuals that have ligamentous talonavicular injury and calcaneocuboid injury. We know, so impaired coupling of the rear foot and forefoot is also plausible because of the nervous damage. And then, of course, the inability to decouple the rear foot from forefoot, because if you think about all the trauma that occurs to each of those joint capsules in the kinematic chain, it's highly plausible that because of scarring, you're going to have joint hypermobility, as well as, the neurophysiologic constraint that I discussed before. So we did a study, it was a cross-sectional study looking at 80 individuals with and without lateral ankle sprain and chronic ankle instability. And the one thing that we did not discuss so far is the COPRA group. We know individuals sprain their ankles all the time. And we said that 40%, but 60% go on, and never have a problem ever again. And that's great. That's the COPRA group. So what we looked at is, once again, university, college-aged individuals. The first outcome we looked at is foot morphologic measures. Okay, and we looked at not only the foot posture index, but we also looked at the component measures of foot length, dorsal arch height, as well as foot width. And from there, we calculated the arch height index, the arch flexibility, which is like the arch height index, but only encompasses body mass, to normalize that, as well as foot mobility magnitude. And what we found is no differences between the groups, okay? Now, this, as it pertains to the prior evidence, is mixed, right? So Morrison found that increased arch height, foot size, and cava varus was identified as a risk factor. However, there was 2 other studies that found no link. So our data actually supports the latter supposition that this is not a substantial factor in this population. We also looked at joint mobility measures of both the rear foot and forefoot, looking at, not only sagittal plane excursion, which is the composite of both dorsiflexion and plantarflexion, frontal plane, as well as the rear foot, as well as for the forefoot as well. In addition, we also looked at the first metatarsal excursion, as well as the hallux sagittal excursion. So both flexion and extension of the metatarsal. So just to orient everybody to this figure, these are Cohen's d effect sizes. In the gray circles are your COPRA group. The black triangle are your lateral ankle sprain group. And the black squares are your chronic ankle instability group. And so we're talking about in the weight-bearing dorsiflexion, only the lateral ankle sprain group had significant and large decreases in weight-bearing dorsiflexion. When you're talking about typical open chain goniometric measures of dorsiflexion, both the lateral ankle sprain and the chronic ankle instability group had large and significant decreases, where there was no significant difference in any of these measures for the COPRA group. For frontal plane rear foot excursion, which is the composite of both inversion and eversion, we saw large and significant increases, which kind of makes sense when you talk about ligamentous laxity of the rear foot in both of the clinical groups. Moving on to the forefoot, we saw no significant differences in both the COPRA and the lateral ankle sprain group pertaining to forefoot on rear foot motion, except for the chronic ankle instability still had a moderate effect and significant effect size. Eversion, both the lateral ankle sprain and chronic ankle instability group, once again, large effect sizes. First metatarsal sagittal plane excursion, as well as the first metatarsal plantarflexion. Once again, large increases. Now I can't make heads or tails over why we found significant decreases in hallux sagittal plane excursion and only in the COPRA group. So I don't have a good explanation, but it was a finding. So for joint plane measures, these are your typical passive mobility assessments, no different than the anterior draw, posterior draw, some of these lateral medial glides, as well as the internal and external rotation, as well as looking at forefoot motion, looking both at inversion, eversion, abduction, adduction, as well as the first tarsal, metatarsal, and metatarsal phalangeal, dorsal and plantar glides. Once again, clinical group, large and significant increases in both the lateral ankle sprain and chronic ankle instability group for both the anterior draw. But here's this one. So Joe Park, who is a foot and ankle surgeon, and he was on my committee, and he's like, John, anterior draw is important, yes, but I actually feel that the internal rotation, the dial test of the rear foot is more important. And it's just interesting that we found, even larger effect sizes compared to your traditional anterior draw in both the clinical populations. And only the chronic ankle instability group had large significant increases in subtalar inversion. In the forefoot, we saw diminished movement of forefoot on rear foot inversion for both the lateral ankle sprain and chronic ankle instability groups, and only the chronic ankle instability group had large and significant increases in first metatarsal. Looking at general laxity, and this was the mean laxity measures of all the rear foot and forefoot measures, we found that the chronic ankle instability group had large and significant increases, and only the lateral ankle sprain group had large and significant, moderate decreases in mean forefoot motion. So to summarize, decreased midfoot joint play in both the lateral ankle sprain and chronic ankle instability groups was likely a result of that calcaneocuboid disruption that we discussed earlier. And both clinical groups had significantly increased forefoot and rear foot motion and first metatarsal. So it's possible because of a more inverted rear foot, these individuals have to keep the medial forefoot in contact with the ground and are required to have greater plantar flexion. And there's also a possible shift in total range of motion, similar to what we see in the shoulder, where you'll see like pictures that have extreme increases in external rotation. But if you look at side-to-side differences, is typically the total arc of motion should look vaguely similar side to side. So it's possible that in this particular case, the shift in motion further into eversion is similar to the phenomenon we see in the shoulder. So the question lies, because that's one of the limitations of cross-sectional studies, is that the measures of association, you can't establish causation. So which came first, the chicken and the egg? Now, there was a study that recently came out that actually looked at two genetic polymorphisms, which are in charge of collagen synthesis. And they actually found that it increased the odds ratios. So those individuals were twice as likely to sprain their ankle than the individuals that didn't. And the other polymorphism that's found is actually found inside fast twitch muscles. So talking about all the neuromotor deficit that we see in like the fibularis longus, it could be pertaining to the rate of contraction and the ability to counter those external moments. So I had the pleasure, and I'm going to talk about this study a little bit more as we get into treatment. And I was privileged to actually be a part of this in the revision of the clinical practice guideline put forth by the Academy of Orthopedic Physical Therapy, which is part of the American Physical Therapy Association. And so we purposely said it's important to clinically routinely assess the multiple segments of the ankle-foot complex. And I think this is uber important because you have to remember a lot of times, we talked about the Ottawa rules, but a lot of times these clinical presentations are subclinical, right? You may look at these individuals, and unless you examine it and provoke it, they may not be reporting, midfoot injury. So I think it's important to, once again, assess each of the segments of the foot. So I'm going to shift gears a little bit, and we're going to talk about intervention. And I think, this is important. This is an important segue. It's important to remember the tenets of evidence-based medicine, right? I'm going to be presenting a lot of the evidence, but your clinician experience as well as patient preference are going to play, even more importance as you're talking about interventions. And because we're in sports medicine, we're always thinking about outcomes, right? Ultimately, yes, we're looking at these pathoanatomical perspectives, but I think it's important to contextualize, so what? What does that mean as it pertains to their ability to do the subordinate elements of the sport, as well as, their ability to participate in practice and games? Because I think that has a true bearing. Now, I think it's also important to contextualize the environmental factors of why somebody can't get back into sport, as well as the intrinsic factors, such as, there's a psychological comorbidity, which is going to drive outcomes. There are perceptions of care. There are perceptions of their ability to return to sport. So I think it's all important to factor in the individual patient. So here's that same model, and this was contextualized by my PhD advisor, Jay Hurdle at University of Virginia, and Dr. Reve Corbett, and they contextualized this, using international classification of function put forth by the World Health Organization. And we talked about the heterogeneity and all the facets that feed in. And then once again, the perceptual pieces of how that translates to function and the mediation, whether that be social support from the coach, from the team, from the medical staff, as well as the intrinsic factors. So I think it's important to contextualize how you approach treatment and engage the multiple facets of the team, including the coaching staff, strength and conditioning staff. I think it's all very important. So primary prevention. So, we talked about bracing. Bracing and actually taping are both beneficial for primary prevention. However, braces have been shown to be more cost effective because of the less man hours involved pertaining to, sizing, distributing, teaching the patient, and then send them off with that brace. And I think that's important when you're thinking about high-risk tasks. Now, the evidence, though, is weak pertaining to the use of prophylactic exercises. Now, I want you to contextualize that, though, in the potential benefit and risk, okay, from a cost perspective, from a injury perspective of performing those activities. Perhaps, it should be done as part of the normal strength and conditioning that these individuals are conducting. But so that's the evidence for primary prevention for ankle sprains. And then secondary prevention. So, primary prevention, remember, is left a boom. So that's before they had an index injury. Secondary prevention, once again, is following the injury. Somebody had an ankle sprain. And by the way, these individuals are at risk for re-injury up to a year after, and that risk drops off after that 12-month period. Okay, so it's something to consider, especially when athletes are participating in sport, about secondary prevention and use of bracing, especially if they're doing high risk, especially court sports, cutting sports, some of those other facets that were discussed earlier. So for acute and post-acute ankle sprains, call the police. Everybody heard about RICE. There's been a shift, and there's a couple of the acronyms out there. I like police because it stands for protection, optimal loading, okay, and then of course the ICE compression elevation aspects that we all know well. And what drives the speed of protective and optimal loading has to do with once again that frag pattern. We know that contusions are ubiquitous. It affects 76% of individuals. And that was reported by Carr in 2015, that, we're talking about talar contusions. In a quarter of the individuals, they'll have tibial contusions. So all these facets, when you think about weight bearing, and how long osseous contusions take to remedy. So it's just one of those factors as you're making clinical decisions of how you're going to manage this patient and prognosing how long they're going to be out, and that communication for realistic. That's where I think you need to use your clinical judgment. And remember, this is not a recipe. This is just something to kind of orient and train you to say, hey, what's out there. Therapeutic exercise, strong evidence, for rehabilitation exercises such as range of motion exercises, neuromuscular, posture education, gait training, so, and that's both in the clinic and at home. So we did a systematic review a few years ago, and that's why this was rated D for mixed evidence. So we actually found that for less than 8-week chronicity, individuals who had supervised exercise actually did better than the home exercise group. However, that fleeted, and actually on the tail end, there was no real differences later. So there may be some benefit earlier on, but just something to come. But once again, how, whether you put somebody, you have to take that individual patient. And some patients are going to need that supervision and coaching and the psychological facets of working with somebody who's going to encourage them and teach them and hold them accountable to their compliance of their programs. Manual therapy. Now, I think this is very, very important to understand. These are augmentative. I am not, no way, shape, or form saying manual therapy alone or acupuncture. These should be considered augmentative interventions to use with therapeutic exercise, to use with the other interventions. So think about it as augmentative interventions. But there's strong evidence for some of these manual therapeutic techniques. Okay, pertaining to acupuncture, I think there's conflicting evidence, and I think there's a dearth of well-designed interventions, and even the way they approach from a research perspective. If you look at one intervention isolation, well, yeah, of course, may it help? I don't know, probably not. Especially if you're not doing the other thing. So I think it's important to kind of contextualize that recommendation, that at this point we had to give it a D recommendation, which is indicative of conflicting evidence. Cryotherapy, diathermy, low-level laser. Once again, there's some weak evidence for utilization. I'm not going to get into the ICE debate because I can make a lecture for all on that on. But that's the current recommendations. Once again, augmentative, to get the patient to to do the real intervention, which is the exercise, the stretching, to make it palatable. Electro Therapy had a recommendation for D, which is once again conflicting. I think from a research perspective, I think you're challenged with the same things, looking at this modality in isolation. Now, ultrasound. Great modality, not the therapeutic. So there's strong evidence against the use of therapeutic ultrasound. And if you see my little picture right here, I think there's and this was not addressed because there's not much evidence at this point, but, as a feedback tool from a psychological perspective to contextualize their injury and then reassure them, say, yes, this is going to scar down. I think that there's a big, a potential utility in the use of ultrasound imaging from a therapeutic perspective. So just something to kind of think about, and that's there's a lot of research that's going on now and going down that route. NSAIDs, you're all primary care, sports medicine physicians. NSAIDs, I think Dr. Henne did a good job. She said 14 days, but I want to caveat that, based on the evidence, right? If somebody, if it personally, we know that it's ubiquitous to have, contusions, we know that it's bony contusions, fractures are pretty frequent, with about, 20% of your individuals that'll have a fracture with, avulsion of the fibula or the fifth metatarsal, which is the second most common occult fracture in this population. So from that perspective, you have to weigh out the pros, cons. The other perspective, there's a lot of evidence coming out of the exercise physiology world about how NSAIDs, inhibit myokines, which is what you want to have, as a result of exercise. So, once again, use good clinical judgment. I'm not here as a PT to tell you guys, how to prescribe medication, but just, consider the evidence as you approach it. And I don't think it's also on the flip side of that. I don't think it's good to let somebody, suffer if they're having a substantial amount of pain, from a psychological perspective. I think that's not going to help them either, right? And it's not going to allow them to do some of the exercises that may be therapeutic. So this has from a weak evidence perspective, may prescribe because of the mix of evidence about pro and con. And once again, that could be a lecture all on its own. Return to sport criteria. I think return to sport and graded exposure and having supervision, and collaboration, communication between your rehabilitation staff, the physician staff, the staff and strength and conditioning, as well as the coaches, and graded exposure, I think, is a good thing. And once again, you have to judge that on the individual presentation of that individual athlete. I think Dr. Henne presented this in a different way, straight from the bird work. So typically you're looking at, and remember, these are projected. Once again, this will be mediated based on the blast pattern of impairment. And remember to treat the individual, but this will give you a good overview of timelines as it pertains to return. So for chronic ankle instability, therapeutic exercise is great. Remember I said that it wasn't great for prevention. It's great on the tail end, and there's strong evidence for it. Same for manual therapy. Dry needling is one of these new interventions, which is similar to acupuncture. But right now there's some weak evidence to support the use of dry needling. Combined treatments, I think the amount of evidence is starting to still continue to come in, but there's moderate evidence to support multimodal exercise and other augmentative interventions. Now, I purposely wanted to include psychological return, and you kind of heard me say, I think there is more to this, and it's partly because I was corrupted by my sports medicine physician mentor, Captain Steve Bliven, who's now retired. And he used to always tell me, you got to treat the patient in their minds, before all the evidence started coming in. And so I'm happy to see this is becoming more and more accepted and increasing amount of evidence to support this. However, at this point, it's theoretical and foundational. I think there's going to be more evidence to come to support this in the next iteration of the clinical practice guideline. So future directions. We're funded right now to do some of the foot intensive rehab program. And we have a project right now funded with University of Kentucky, where we're looking at some of the intrinsic foot exercises, plantar massage, which has been shown to upregulate the plantar sensation. And these patients do better on balance tests after doing some of these plantar sensory interventions. Now, I think it's important. We're going to do an AAB design, and we're going to see how that affects not only near-term outcomes as well as long-term recurrence. The second, and this is basically amplification of what I just discussed, talking about, and that's actually in collaboration with Dr. Hu and my colleagues up at the Primary Care Sports Medicine Clinic up in Camp Pendleton. The second intervention is Iraqi Rehab. And think about this as an ecologically valid return to sport activity that's important, especially in the military population. I can't tell you how many ankle sprains I had from hikes or doing land navigation at night when you have decreased visual input. So this is to get that proprioceptive. And as we're actually progressing these patients, once again, AAB design, we're assessing that. And that's also going to be up at Camp Pendleton. Really excited about these projects that we're going to be, we're just starting past the regulatory and going to be doing some of the execution phase. And with and now I think we're at the questions, and if anybody doesn't want to pipe up now, or you watch the video, I'm on Twitter, or if you scan the QR code, that will give you all my contact information and work. So I will now open it up for questions. And let me unshare my screen.
Thank you, Dr. Henne. Thank you, Dr. Frazier, for the excellent talk. That was definitely a lot of educational good stuff for the CAQ as well. We did have some questions through the chat. I know we're running a little tiny bit late, but I wanted to get to some of those questions that our audience has posed. So the first question is for Dr. Frazier. I know that you wanted to avoid the whole ice debate, but the first question I think, can you comment on, even though that RICE is an outdated treatment modality, we still continue to see wrapping and icing post-trauma?
Yeah, I mean, from a neurophysiologic perspective, I mean, superficial ice only penetrates a short, it only goes, I think, a millimeter or two deep. I mean, it really does not penetrate to the mouth. But I think what the neurophysiologic response that we have as part of the ice, that sympathetic, and then of course you have that perfusion increase following the ice, and may have some benefit. I I think the question, I think when you're talking about from a healing perspective and whether it actually inhibits, I think, when you talk about NSAIDs and something that is like, whether that be oral, even, injected, I think has more of a salience, as if you're worried about, inhibiting the tissue healing. So I think from that perspective, I don't know. I'm not in any camp. I'm still waiting for the evidence. I clinically, I would still absolutely use it because the patients feel better after it, and it enables them to do the other exercises, and that I think that's what really matters.
Okay, thank you. The next question, I'll leave it up for either of you to answer.
Well, hold on. I'm interested here, Dr. Henne.
Okay.
Yeah, sure. So when we look at RICE, police or RICE, rest ice compression elevation, I know there was a recent study that came out with the Journal of Athletic Training, and they were looking at RICE modalities and saying, as of right now, insufficient evidence, right? And they've looked at multiple randomized controlled trials, and they're saying, have the conversation, talk to the person who's going through it, give them what the evidence is. These are the concerns. These are the situations that it would be beneficial for, and then have that collaborative approach. That way, you're just demonstrating, okay, we're a team on this. How are we going to be approaching it? Give them all the information, and let them choose individually what's going to work best.
Okay, thank you. Next question, I think we have time for one more. What is the clinical definition for chronic ankle instability?
Yeah, well, we're about a year and a half into, since COVID started, I still talk with it muted. So chronic ankle instability was operationally defined by the International Ankle Consortium as an individual that had a substantial sprain, had greater than 1 year chronicity. Because remember, I think it's normal to have instability up to a year following the sprain. And then remember, we're talking about an index sprain here, right? It's normal to have, but at some point between point of injury to 12 months, that should resolve. Those individuals that have continued persistence, and that affects function. I think that's the important piece, because that's the burden, right? Piece. And remember, this is a sliding scale. With Dr. Hurdle from Virginia in that new model, because we talked about it a lot. It's like, well, it's kind of dichotomous right now, but there's always there's a sliding scale of severity, in these individuals, right? And so I'm happy to see that was implemented into the model, into the updated model. So I think from that context, that's chronic ankle instability. Now, and by the way, in chronic ankle instability, you could actually have somebody who has primary neurophysiologic deficit and have a fairly mechanically stable joint. They may have some laxity, but not a whole hell of a lot. And vice versa, you may have a primary mechanical ankle instability where they have substantial joint laxity, but limited neurophysiologic. Typically, you have both, and I think once again that pertaining to treating that individual athlete or individual patient, I think it's very important to contextualize that and treat that patient and the impairments they have.
Dr. Henne, anything to add?
I think you did a fantastic job at describing chronic ankle instability and its definition.
Okay. I think we have time for one more question that was listed in the chat. This one, I think, specifically was for Dr. Fraser. There was some confusion on the study on foot morphology not playing a role in lateral ankle sprains. Does this mean that pes planus does not contribute, but foot positioning such as over-inverted walking position would matter?
So once again, many of these studies, in my particular study, it was a cross-sectional study. So we're looking at it after the fact, right? We didn't find a difference, right? And, I think when you're talking about causation, I think the jury's still out, because there's been two studies and we're talking about prospective longitudinal studies that talked about eversion as a risk factor. whereas there's others that have not shown that as a risk factor. So once again, evidence is mixed, right? And then there's always evidence. I think there's always more research. It's a little self-serving as a scientist, right? There's always more research to do, but I think it raises more questions than answers. So once again, here's the other caveat to that. Same thing with treatment after the fact about, I think one of some of these problems about some of the intervention studies for protection is that we'll take a intervention and throw it against, and it's not individualized to the particular patient. And I'm specifically looking at Dr. Hu because we have a systematic review that is archived and a review looking at prophylactic orthotics or shoes. And once again, we found in that meta-analysis that it was not protective, at least in the military population. So once again, individualized prevention, individualized. I use the exception for ankle braces. I think that helps everybody.
Okay, thank you for your response. Well, it doesn't look like there's any other questions. We've answered them all. So I'd like to thank everybody for your attention. I apologize for going over the time limit just a little bit, but I think, those are important questions to answer. So certainly thank you to Dr. Henne and Dr. Fraser for giving this talk. Thank you to the subcommittee and the AMSSM for sponsoring this.